Dear friends, this talk is regarding the antibiotics for CNS infections, the talk which was delivered on the 3rd of February for the National Board webinar, and it is a repetition of that recording. We all know that the antibiotics are essential for any infections, and in CNS is no exception. And when we think about the use of antibiotics for the infections pertaining to the central nervous system, the same rules of PKPD applies for all other infections too. So if we just recapitulate, we know that according to the pharmacokinetic and the pharmacodynamic principles about the antibiotic use, there are three distinct groups of antibiotics. One, which have a concentration-dependent killing with prolonged duration of effect, such as the aminoglycosides, fluoroquinolones, metronidazole. And for these antibiotics, it is essential to maximize the concentration of the antibiotic by administering a loading dose. So these are the antibiotics which has to be administered by a bolus doses so as to ensure that the maximum concentration, that is the Cmax, to the MIC, that is the minimum inhibitory concentration ratio, this is maximum to give the maximum effect, either in terms of sedal effect or the static effect. These antibiotics, which are concentration-dependent killing antibiotics, they also have a prolonged duration of effect even after the cessation, even after their levels in the blood are not detectable because of a post-antibiotic effect. The second group of antibiotics are the ones which have a time-dependent killing or a time-dependent action with limited duration, such as the cephalosporins, erythromycin, penicillins, in which it is necessary to give an infusion dose so as to maximize the time during which the antibiotic concentration remains well above the minimum inhibitory concentration. So the greater the time over the MIC, the greater would be the efficacy of the antibiotic in terms of its sedal or static effect. The third group of antibiotics are the ones which are time dependent with moderate duration of effect. That is, their action continues for a little bit of time more after their discontinuation of the infusion. This includes the azithromycin, clindamycin, tetracyclines, etc., where the pharmacological goal is to maximize the quantity of antibiotics over the period of time. Or in other words, these antibiotics need a loading dose followed by an infusion so that the area under curve is maximum. And this area under curve by MIC determines their sedal or the static effect. Now, it is important also to realize that most of the antibiotics which are sedal can be static at a lower dose, and some of the antibiotics which have its action as a static effect on the organisms can be sedal when the dose is high. And this particularly relates to the concentration-dependent killing antibiotics. Now, besides this, the antibiotic dosing regimens are also modified by other factors, and these are the ones which affect the pharmacokinetics of the drug. That is, what the body does to the drug in the form of absorption, distribution, metabolism, and excretion or elimination, ADME. So these can be influenced because of the patient factors such as the age, obesity, presence of comorbidities, physiological changes, and a good host immune response. On the antimicrobial factors such as the solubility, because certain antibiotics are lipophilic, whereas some are hydrophilic. So the ones which are lipophilic will have a greater volume of distribution. The ones which are hydrophilic will have a poor volume of distribution, so they will be more concentrated in the blood, and hence their action will be more in the presence of organisms that are found in the blood or in the presence of positive blood cultures. So likewise, the volume of distribution is also influenced in the different states. We know that in the sepsis with the leaky capillaries, a lot of volume escapes the intravascular compartment into the extravascular compartment, particularly in the interstitial spaces. And in those cases also, the free concentration of the drug can increase in the blood, which besides causing the good effect can also produce toxicities because the free concentration of the drug rises. Likewise, protein binding also increases the free concentration of the drug. A reduced clearance also increases the concentration of the drug, whereas an augmented clearance, particularly in the early phases of septic shock, reduces the drug concentration, thereby necessitating a loading dose and higher dosage forms. So besides this, we know that the MIC values are important. The heteroresistance, that is resistance of one group of antibiotics to a particular locus of the drug, which acts is important. And of course, the laboratory variability. So these are all the factors which influences the antimicrobial dosing. Now, in order to optimize them, there are certain dosing nomograms which can be followed, which are available, but sometimes the in vitro results may not extrapolate with the vivo results. Therapeutic drug monitoring, this is also an important mode for optimizing the dose by looking into the troughs and the peaks, and therefore they can be used particularly when resources are available. There are certain dosing softwares which calculate the doses based upon certain parameters that can be fed into the computer. And alongside, there are new novel technology-based strategies which are emerging, and some of which are underway through the application of AI that can be used for optimizing the antibiotic dosage in the near future. But needless to say, all of this can have a better clinical outcome, reduce the risk of toxicities, and most importantly, prevent antimicrobial resistance. A large chunk of the antimicrobial resistance that is happening these days is because of the inappropriate dose of the antibiotics. Now, coming to the CNS compartment, if we see, we have that the intracranial intraspinal space consists of several compartments. It has the intramedullary and the extramedullary compartment. The extramedullary has both intradural, extramedullary, and extradural. The intradural also has subarachnoid and the subdural. And it is to be understood that even in the individual regions of one compartment like CSF, strong differences in drug concentrations can occur, particularly between the ventricular, cisternal, and lumbar parts of the compartment, because many of the drugs which are heavy, which have a which are with the weight and the solubility, they will tend to spread along the gravity, and sometimes their concentrations are much higher in the ventricular, followed by cisternal, and yet they do not achieve reasonably high concentration in the lumbar parts of these compartments. Now, two important distinctions has to be made which determine a lot about the effect of the drugs, particularly the antibiotics. One is the blood-brain barrier and the blood-CSF barrier. Sometimes they are often confusing, and one thinks that the blood-brain barrier and the blood-CSF barrier are identical, but it is not so. You can see to your left, this is the blood-brain barrier, where we can see the endothelial cells which are separating the brain capillaries and from the astrocytes, whereas to your right, you can see the CSF, which is separating the cuboidal epithelial cells from the ependymal layer of the neurons. So blood-brain barrier is located in the brain capillaries, and it is an endothelial structure to protect the brain from physiological fluctuations in the plasma concentrations of the various blood-borne substances, including antibiotics. And besides that, it also provides mechanisms for exchange of nutrients, metabolic waste products, and the brain interstitial fluid. So the primary determinant in all these cases is the blood-brain barrier, whereas the blood-CSF barrier is created by a layer of modified epithelium that secretes the CSF. So it is the CSF which separates the blood from the action of those on the particular the neuronal sites, because the concentration of this on the CSF is finally determining the action of those antibiotics at its particular target site. Now, if you realize that, then the drug concentrations in the brain homogenates, that is, any of these systems will do not reflect the concentrations in the extracellular space, but it will rather reflect an average concentration of several compartments, which I mentioned in my previous slide. And the microdialysis technique has been used to quantify the concentrations of these antibiotics or anti-infectives in the extracellular space of the brain of the humans. But still, CSF concentration still represents the closest approximation of the drug concentrations in the extracellular space of the CNS compartments, which are available for the majority of the drugs. So even if we don't have the microanalysis, by looking into the concentration on the CSF, we can reliably estimate the amount of drug that is finally going to reach its target site of action within the brain cells. Accordingly, there are certain antibiotics which have very good penetration into the CSF, such as the fluoroquinolones, metronidazole, fosfomycin, isoniazid, pyrazinamide, flyflucytosine, etc. Some have good penetration only in the presence of inflamed meninges in meningitis, like glycopeptides, macrolides, etc. And some have poor penetration irrespective of whether the meninges are inflamed or normal. And these are the ones like beta-lactams, aminoglycosides, tetracyclines, clindamycin, etc. So that doesn't mean that these antibiotics, which have poor penetration in the CSF, is unlikely to have an effect. They can have an effect, provided that the blood-brain barrier is intact and the sufficient concentration that is available, that achieved in that they can cross the blood-brain barrier, so that when by diffusion, at least some amount can be available to mix with the CSF, and they can spread along the length of the column which the CSF circulates. So the CSF and the interstitial space of the nervous tissue are no homogeneous compartments. So the concentration of a drug in the ventricular and the lumbar CSF can strongly differ. Again, because it depends upon the solubility, the weight, and the gravity. Now, let us follow this case and walk along to see how these drugs can be used and what are the agents we have in different infections of the CNS. A 30-year-old male with a history of fever, headache, drowsiness, and neck rigidity and vomiting for 4 days comes to the emergency. On examination, pulse is 106, BP is 110/60, temperature is 101.4, respiratory rate is 24, GCS is around 11, hemoglobin is 9.5, TLC is 14,000, predominantly polymorphs, glucose is 80, sodium potassium is 135 and 2.8, slightly hypokalemic, urea creatinine is normal, the chest X-ray is normal, the USG abdomen and the lungs are normal with the normal IVC. The CT head shows mild ventriculomegaly with sulcal effacement and obliteration of the basal cisterns. The MRI shows diffuse hyperintensity in the cerebral sulci on FLAIR images. And the CSF glucose shows a fall in the glucose of less than 50% of the blood glucose, rise in proteins and the neutrophils. So if you ask a presumptive diagnosis, so this can be either meningitis or meningoencephalitis or encephalitis. But considering these distinctive features, it is more towards meningitis or meningoencephalitis, because if you see that fever and leukocytosis occur in all of them, but meningeal irritation is usually absent in the local rigidity and photophobia. It is absent in encephalitis, present in meningitis and meningoencephalitis. Mental status alteration is nearly always present in encephalitis, sometimes in meningitis, and often in meningoencephalitis. Seizure is very common in encephalitis. Focal neurological findings are a hallmark feature of encephalitis and develop in half of the patients in meningitis and a little more in meningoencephalitis. And the typical pathogens which are responsible are primarily bacterial in presence in meningitis, whereas they can be mixed in meningoencephalitis and primarily viral in encephalitis. So considering all this, our patient may be having most likely to be of meningitis. So what are the most common organisms which causes acute bacterial meningitis? If a patient is coming from the community, the common causative organism include strep pneumoniae, Neisseria meningitis, other streptococci, H. influenzae, and Listeria monocytogenes. Some causative organisms can be there, which can include Staphylococcus, gram-negative bacilli, although rare in the community, Pseudomonas and Acinetobacter. There are certain common risk factors like otitis media, elderly population, depressed immunity, either because of the disease or because of long-term use of steroids, etc., and prior antibiotic use. In contrast, if it is a nosocomial meningitis, then the commonly implicated organisms are cons, especially Staph epidermidis, Staph aureus, Acinetobacter, Pseudomonas, and Enterobacteriaceae. The risk factors are repeated catheterization, higher catheter duration, repeated or regular CSF sampling, the presence of concomitant systemic infection and surgical technique like a subcutaneous tunnel DVD, Rickham reservoir with percutaneous CSF drainage, etc. So if the patient is a post-operative patient, what are the common organisms causing post-craniotomy meningitis? Again, most commonly implicated organisms are the Staph aureus, that is the cons, especially Staph epidermidis, Enterobacteriaceae, Acinetobacter, and Pseudomonas. The risk factors include CSF leak, presence of an EVD, long duration of drainage, multiple operations, lack of antibiotic prophylaxis, and emergency surgery. There are certain organisms which produces post-neuraxial blockade meningitis, and out of them, viridans, streptococci, and Staph aureus are common organisms, and exogenous inoculation is the main risk factor. In post-head trauma meningitis, again, it is primarily can be because of cons, and Enterobacteriaceae follow as the microbes, and they can occur following prolonged hospitalization, insertion of lumbar and ventricular drain, etc. So all these are the risk factors which are present in post-head trauma meningitis. CSF leak, single glove use, a number of times shunt exposed to breech surgical gloves are also considered as risk factors in post-head trauma meningitis. Now, what are the empirical antibiotics of choice for treating acute bacterial meningitis in the ICU? So whenever the patient is in the ICU, we assume that the person is more sick. And of course, we need to see that what are the other likely sources of infections besides the CNS. And depending upon that, the antibiotic which can be administered and which can have an action in the different sites has to be chosen. So if it has to be chosen primarily for CNS, the choice of antibiotics depends on the likely causative organism, and that will vary from place to place, time to time, situation to situation. So an understanding of the local flora and the sensitivity and resistance of the local flora to the conventional antibiotics should be known. Mechanism of infection and patient's predisposing condition should be understood. Most commonly recommended empirical antibiotic regimes include a third-generation cephalosporin plus vancomycin, the third-generation cephalosporin monotherapy, and penicillin monotherapy. Addition of amoxicillin, ampicillin, or benzyl penicillin is recommended in patients over 50 years because of need to cover Pseudomonas. And the duration of antibiotics is based on suspected or isolated organisms, which is around 10 to 14 days for strep pneumoniae, around 14 to 21 days for Streptococcus agalacti, 7 days for Neisseria meningitis or H. influenzae, and slightly longer for aerobic gram-negative bacilli, for that is 21 days for Enterobacteriaceae, and also sometimes increased to Listeria monocytogenes is also for 21 days, nearly 3 weeks. If no microorganism is identified, then also the treatment should be given for at least 10 to 14 days once the clinical picture suggests meningitis and the patient responds to the antibiotics in the initial period. Now, there are recommendations for empirical antimicrobial therapy in community-acquired bacterial meningitis, which in according to the age between 16 to 50 years, where the Predominant pathogen is Neisseria meningitis and Streptococcus pneumoniae. This is global. And here also vancomycin plus a third generation cephalosporin, and above 50 years where strep pneumonia, Neisseria meningitis, Listeria monocytogenes, as well as aerobic gram-negative bacilli are there. There also vancomycin plus a third generation cephalosporin plus ampicillin is recommended. In the presence of risk factor like alcoholism, altered immune status, in those cases also vancomycin plus a third generation cephalosporins plus ampicillin is indicated. So then in regions with very low rates of penicillin resistance, monotherapy with penicillin may be considered, and that's why it is a difficult proposition, particularly in our country. And in places where it is very low, that is in the Scandinavian countries, many experts recommend combination therapy, avoid combination therapy, but otherwise combination therapy is recommended until the results of susceptibility testing are available. Now that we have rapid diagnostic tests available, so they can help us guide in deciding whether we need any third antibiotic. But in all cases, probably vancomycin and the third generation cephalosporins like the ceftriaxone are useful choices which can be relied upon unless the patient has some form of resistance or has an altered immune status. Now, empiric antibiotics, according to the suspected pathogens and age, if you suspect meningococcus, pneumococcus, or H. influenzae, the empiric antibiotics remains the same. If the patient needs to be administered as has allergic to penicillin and we need penicillin alternatives, then either meropenem or fluoroquinolones can be administered. In age more than 50 years, in addition to that, pneumococcus, listeria, and gram-negative bacilli, if it is suspected, then we have to add ampicillin. And if the patient is intolerant to ampicillin, then of course fluoroquinolones or trimethoprim sulfamethoxazole can be given. In patients with hospital-acquired meningitis where staph or gram-negative bacilli or even pneumococcus may be the cause, ceftazidime or cefepime can be combined with vancomycin, and meropenem can be added if as a penicillin alternative if there is any such requirement or suspicion. Now, it is very important to remember that vancomycin, when we administer in the presence of drains or in the presence of anything, the dose of the vancomycin increases, and whenever the vancomycin is administered in such high doses, therapeutic drug monitoring will be helpful. But if it is not available, then we need to be very cautious and at least check the concentration once in 2 to 3 days to ensure that the adequate concentration is there in the blood for it to act. Now, if it is administered intermittent infusion, the loading dose of 20 to 35 milligram per kg IV once, intermittent duration is 15 to 20 milligram per kg every 8 to 12 hourly. And if we are able to do a therapeutic drug monitoring, then you can see that the daily area under curve to MIC ratio values should be around between 400 to 600. So if that is there, then it is reassuring that the adequate concentration is achieved. Loading dose is required in critically ill patients, but the loading dose should not exceed 3000 mg, and the intermittent dose should be based on actual body weight. And for therapeutic drug monitoring, the Bayesian software is preferred, although other normograms are also available. If vancomycin is administered as a continuous infusion, then we can give 30 to 40 milligram per kg daily of continuous infusion to achieve a steady state concentration of 20 to 25 milligrams per liter. And whenever possible, we may be considered where area under curve target cannot be achieved, then we can increase the dose based upon the body weight, and we can go up to a maximum of 60 milligram per kg. Now, these recommendations of vancomycin can also change again depending upon the organism and also depending upon the MIC levels. So the latest consensus guidelines for therapeutic drug monitoring of vancomycin identified the 24-hour area under the concentration time curve to MIC as the pharmacodynamic parameter, which is most likely to predict the clinical efficacy. and the bacterial activity being achieved with the values between 400 to 600 has the minimal risk of nephrotoxicity and the maximum benefit. When it comes to cephalosporins, then we should realize that we have a variety of cephalosporins. So when we talk about the third generation ones, we mean cefotaxime, ceftriaxone, and ceftazidime. They have more effective against gram-negative bacilli. They're less against gram-positive cocci. They cross the blood-brain barrier, more effective in the treatment of meningitis, and ceftriaxone effectively is also effective against Lyme disease, but these are not the concern particularly in our country. But selected third generation cephalosporins are the beta-lactams of choice in empiric treatment of meningitis, and these drugs have consistent CSF penetration and potent activity against majority of the pathogens of bacterial meningitis. Only notable exception being Listeria monocytogenes and some penicillin-resistant strep pneumoniae. So for that, usually we need to add ampicillin, or other, if ampicillin is not there, we can add meropenem. So these are the Listeria monocytogenes and penicillin resistant strains are a concern, then definitely it becomes a difficult choice. So what are the empirical antibiotics of choice for treating nosocomial meningitis in ICU? Again, vancomycin in combination with cefepime, ceftazidime, or meropenem is commonly recommended. Alternative regimens include third generation cephalosporin or meropenem monotherapy, or ceftriaxone plus flucloxacin or cloxacin combination. We know flucloxacin is available in India. So limited available evidence shows the efficacy of intrathecal or intraventricular antibiotics in the management of nosocomial meningitis, which are poorly responsive to systemic antibiotics. So if they are not responding initially to the systemic antibiotics, it is unlikely to respond better to intraventricular or in cases of nosocomial meningitis. And colistin may be given if the incidence of carbapenem resistant Enterobacteriaceae or drug resistant Acinetobacter is high in the specific unit. Otherwise, it should be reserved as the last line. If beta-lactams are contraindicated, we recommend replacing them with either aztreonam or ciprofloxacin. Although there are certain problems with ciprofloxacin, but they may be administered in high dose and as infusion. What are the most common organisms causing brain abscess in the ICU? The organisms include Streptococcus, particularly Streptococcus viridans, the organism which is also responsible for post-neuroaxial blockade meningitis, then Staphylococcus, particularly Staph aureus, gram-negative bacilli, anaerobes, particularly bacteroids, Fusobacterium and Peptostreptococcus, Pseudomonas, and H. influenzae. Polymicrobial etiology accounts for nearly 1/4 of the cases of brain abscesses, and the risk factors include otitis media, sinusitis, head trauma, congenital heart disease because of shunt, right to left, hematogenous spread, surgery, immunocompromised status, pulmonary disease, meningitis, and odontogenic infections. So in these patients, if we have a predisposing condition like HIV, we have to think about toxoplasma, we can Listeria monocytogenes and Cryptococcus. If the patient is neutropenic following cancer or chemotherapy, then aerobic gram-negative bacilli, Aspergillus, Mucor, Candida, and Scerosporium species. If the patient is post-transplant, we can have to think about again Aspergillus and Candida, Mucor, Scerosporium species, Enterobacteriaceae, etc. If there is contiguous spread of bacteria, particularly in penetrating trauma or neurosurgery, they are primarily Staph aureus or Staph epidermidis, followed by Streptococcus, and rarely Enterobacteriaceae and Clostridium. Otitis media or mastoiditis against Streptococcus, followed by bacteroids and Prevotella. In paranasal sinusitis against Streptococcus, followed by bacteroids, Enterobacteria, Staph aureus, and Haemophilus species. Hematogenous spread can be due to following lung abscess, bacterial endocarditis, congenital heart disease, dental infection. Again, the organisms would vary. Now, even in these patients, whenever we think about invasive fungal meningitis, then that has to be differentiated. That the common way of differentiating is by looking into the radiological features, because in cases of brain metastasis, there will be a thicker ring enhancement. Infarction, we have a gyral enhancement. With no enhancement, because distribution conforms to the vascular territory. In bacterial abscess, there is a thicker ring enhancement with reduced diffusion in the necrotic center. Center is necrotic. In toxoplasmosis, there is usually no reduced diffusion in the necrotic center, and that's what differentiates it from bacterial abscess. In demyelinating lesion, there is incomplete ring, and in enlarged perivascular space, there is no enhancement. So, but whenever there is reasons to have fungal meningitis, we have to consider the medical therapy. For aspergillus, it is voriconazole. In candida, it is amphob plus flucytosine, initial medical therapy. Although alternatively, we can see that amphob can be used in most of the situations, bearing only one pseudo-Escherichia where voriconazole or either itraconazole needs to be used. And in some cases of Cryptococcus, besides amphob and flucytosine, we can think about fluconazole. So what is important to note here is that in such many form of meningitis, usually candida the use of candida is less, and therefore we rely more on amphob rather than on the echinocandins. So optimal therapy or fungal brain abscess generally requires both medical and surgical approach. A delay in surgical drainage and decompression can be associated with high morbidity and mortality. And brain abscess in the early phase of cerebritis may respond only to antimicrobial therapy without any surgical drainage. But if there is no response within a span of 7 to 10 days, then surgical approach should be reconsidered. What are the empiric antibiotics of choice for treating brain abscess in the ICU and for how long? Most common empiric treatment is third generation cephalosporin combined with metronidazole. For these are the anaerobic infections when it is suspected, and the antibiotic duration is 4 to 8 weeks. Add vancomycin if there is a high likelihood of MRSA, and vancomycin plus ciprofloxacin if beta-lactams are contraindicated, and aztreonam if ciprofloxacin cannot be given or ciprofloxacin is contraindicated. So minimum 4 weeks of therapy. However, the duration may be extended according to the findings in the clinical findings as well as the radiological findings, irrespective of aspiration or excision of the abscess. Now, there are sometimes undifferentiated CNS infections, and there is one empiric regime for such undifferentiated CNS infection, which combines 2 grams of ceftriaxone with 10 milligram of 10 mg of dexamethasone and 10 milligram per kg of acyclovir. So 2 grams of ceftriaxone IV, or alternatively, one can give 2 grams of meropenem if the patient has history of allergy to advanced generation of cephalosporins. 10 milligram of dexamethasone can also be given, or 60 mg of IV methylprednisolone. This steroid should ideally be given simultaneously or before antibiotics, but still it's still recommended up to 4 hours after the first dose of antibiotic as per the European guidelines, or up to 12 hours after antibiotic initiation as per the British and French guidelines. So this is there, and 10 milligram per kg of acyclovir IV. Some practitioners also add vancomycin and ampicillin. The only reason to use vancomycin is highly drug-resistant pneumococcus, whereas the only reason to use ampicillin is for Listeria monocytogenes. So this regimen is for patients with suspected meningitis or encephalitis prior to obtaining CSF results, or where the CSF results fail to grow or there is a doubt about the CSF report, one can follow this regime. Since there is a limited penetration of intravenous colistin to cerebrospinal fluid, so intrathecal or intraventricular treatment is applied in CNS infections. In this case, on day 1, we can give 5 milligram over 24 hours. On day 2, we double the dose, and we have to dilute colistin with preservative-free NaCl to a concentration of 5 milligram per ml. And on day 2, it is important to add sufficient quantity of preservative-free NaCl to attain a final volume of 5 ml. And the solution remains stable for around 24 hours. But it is to be remembered that intraventricular and intrathecal routes have been recommended in patients with CNS device infections. And in the absence of device infections, there is not such robust evidence is not there. And it is only for difficult to eradicate infections or patients who cannot undergo the surgical removal of infected devices. Otherwise, this has limited space. Empiric regime for viral CSF pattern, again, 10 milligram per kg, 8 hourly of acyclovir is the cornerstone for this regime, pending return of HSV and the varicella zoster PCR results, if PCR facilities are there. Also consider doxycycline 100 milligram twice daily if tropical fever or tick-borne encephalitis is a concern. Listeria can mimic a viral pattern, so listeria coverage must be considered in patients who are at risk for this, particularly those who are old, immunosuppressive therapy, or immunocompromised patients, long duration of steroid therapy, etc. If the CSF lactate level is normal, then listeria doesn't need to be covered. And this is a very important, that lactate is usually, most commonly, it is elevated. So if you talk about acute viral encephalitis, herpes simplex virus 1 and 2, varicella zoster, and all these are covered by the acyclovir, and sometimes ganciclovir is required. And the human herpes virus and rabies is, although it's rare, but in many patients who are immunocompromised, in whom varicella zoster virus, cytomegalovirus can be there, they may require dual antiviral because one may not be sufficient. Immune mediated encephalitis, which is also sometimes manifest with similar mimics acute infections, in those patients also corticosteroids or plasma exchange can be inefficient, and in some patients both IVIG and plasma exchange along with steroids can be tried. So for definitive therapy, if it is strep pneumonia, penicillin sensitive, that is MIC of less than 0.06 to 0.1, the standard therapy is penicillin or ampicillin. Alternative is ceftriaxone. If it is penicillin resistant but cephalosporin susceptible, standard therapy is ceftriaxone. Alternative is cefepime or meropenem. If it is cephalosporin resistance, that is MIC is greater than 1 to 2, then the standard therapy is ceftriaxone plus vancomycin or ceftriaxone plus rifampicin. Although rifampicin, we need to be careful in a country like India, where the the tuberculosis is high, and alternative therapy is linezolid, and the duration of treatment will vary from 10 to 14 days. For Neisseria meningitis, if it is penicillin susceptible, the standard therapy is penicillin or ampicillin. Alternative is ceftriaxone. If it is penicillin resistant, then can be ceftriaxone. Alternatively, we can try cefepime, meropenem, or ciprofloxacin. The duration is less. Listeria monocytogenes, again, the standard therapy is ampicillin or penicillin, and alternatively, one can look for meropenem, trimethoprim, sulfamethoxazole, and linezolid. The duration is longer. And in patients with rhomboencephalitis, they may require even longer courses, going up to 2 months. That is 8 to 12 weeks, 8 to 10 weeks. H. influenzae, again, beta-lactamase negative, ampicillin sensitive, standard treatment is ampicillin. Alternatively, we can go for ceftriaxone or cefepime. If it is beta-lactamase negative, ampicillin resistant, then the standard is ceftriaxone. Alternative is ciprofloxacin. If it is beta-lactamase positive, again, ceftriaxone, and alternative being cefepime or ciprofloxacin, duration being around 7 to 10 days. Staph aureus, usually we go for penicillin, and alternative being vancomycin or linezolid. MRSA, we go for vancomycin. Usually we don't use rifampicin in our country, but it can be used. Alternatively, one can try for linezolid. One shouldn't try teicoplanin because that doesn't achieve a good concentration, so it is not useful generally, but trimethoprim, sulfamethoxazole, if sensitive, can work. In case of vancomycin resistant, one can think about going for linezolid. Alternative therapy is daptomycin. Duration is again for 2 weeks. In cases of spinal infections, one need to go a proper laboratory evaluation and imaging evaluation. And when one sees the go for a pathogen identification, one can go for a targeted antibiotic therapy. But till that time, one should think about the susceptibility to the commonly used agents. The bacteria responsible are Staph aureus, Streptococcus, or MRSA. One can consider clindamycin besides flucloxacin, vancomycin, and teicoplanin. In this patients, teicoplanin achieves a good concentration in the spinal CSF, so that can be used. Ciprofloxacin and cefepime for gram-negative bacteria, and one can think about amoxicillin, clavulanic acid, or meropenem for anaerobic bacteria. So this is the targeted antibiotic therapy once the culture shows positive, and till that time, this can be the empiric form. So the optimal duration of antimicrobial therapy for spinal infections is highly debatable. There is wide variation in the recommendations, but mostly they recommend around 4 to 6 weeks. And some recommendations also carry up to 3 months, particularly in the presence of anaerobic bacteria. When clinical improvement is not achieved after the initial period of conservative treatment for 6 weeks, surgical treatment can also be considered if it is feasible for that. So at the end, my take-home message would be that the knowledge of PK/PD of antibiotics at the blood-brain and blood-CSF barrier is necessary to improve the treatment of CNS infections. The ideal antibiotic compound that would be chosen for CNS infection should be small, moderately lipophilic, should have low plasma protein binding, should have a volume of distribution around 1 liter per kg, and should be a weak ligand at the blood-brain or blood CSF barrier. Otherwise, they will not be able to cross the barrier, reach up to the astrocytes. Some antibiotics like linezolid, metronidazole, fluconazole, as well as some fluoroquinolones, they achieve an area under curve of CSF to area under curve of serum to close to 1. They are extremely valuable for the treatment of CNS infections with highly insusceptible pathogens, because they can clear off the plasma of such organisms within 24 to 48 hours. Some highly active compounds whose permeability is low can be administered directly into the ventricular or lumbar CSF, but as I told before, it is a matter of debate, and only where surgical drainage is not possible and only where we suspect long duration of treatment, then this can be applied. However, the easiest way to increase the drug concentrations is to increase the systemic dose without causing any toxicity, that which is within the safer limits. And for that, if there is the chance of therapeutic drug monitoring, that certainly helps. Thank you.